from Romania, from Timișoara. It's a beautiful, not small, it's a beautiful, nice town, which is very similar actually to Vienna in Austria. It's my hometown where I was born and I studied here. It should have been the European cultural capital of this year, but of this year, 2021, but with the corona and everything, it was postponed. So I hope when everything settles down that you get a chance to visit this beautiful town. I have the office that I run together with Rugina, who is an amazing prosthodontist. And we opened it last year in the middle of the lockdown. So it was very interesting for us, and it still is. So I will be speaking today about how we can choose our TEDs. And I don't know if the listeners are beginners or are more experienced. I try to adjust my presentation accordingly. So it is interesting both for someone who's new with TEDs and who might be afraid to use them, and also for those more experienced. And I would like to begin with an article, a very nice article from Vincent Kokic a few years ago about the mini screws. And it's entitled, "It's Only a Screw." I also heard Bjorn Ludwig speak about this article, which tells us that TEDs are really screws. And first of all, we have to analyze and diagnose, because this gives us the why we do what we do. Without a proper analysis and diagnose, we can have the best screws, but we don't know what to do with them. So first, analyze and diagnose to get us the why, so that we can set the goals, which gives us the what do we have to do. And then we can settle for TEDs and for the rest of the biomechanics. So in this order, first diagnose, then set the goals accordingly to our diagnostics, and then try to figure out how we can get to these goals with the least amount of secondary effects and to be as effective as possible. Okay, so why do we use these mini screws? Because they are a very good anchorage, bone supported, and we can have the movements we want with a minimum numbers of side effects. And I will try to give you some examples later. And I really like the SWOT analysis. I don't know who of you are familiar with the SWOT analysis. They are mostly used in multinational companies, and they gives us the strength, the weaknesses, the opportunities, and the threats. And I did this a long time ago for mini implants, and this is what came out of it. So what are the strengths of the TEDs? They are reliable anchorage. We don't need patient compliance. They are easily placed and easily removed. We avoid secondary effects, and we can reduce treatment time by avoiding these secondary effects that we don't need to have to spend the time correcting afterwards. The opportunities is we may avoid surgery, extractions, extraoral appliance. We can use them very easily in segmental orthodontics in pre-prosthetic cases. And they are very easily placed between teeth exactly where we want them to. The weaknesses, they may break, fail, they are operative sensitive, which means the more we use them, the more experienced we get, and the easily it will be for us to use them. And we need good bone quality to place them. And the threats, there's a risk of loosening, of infection, of root resorption, and sinus penetration. And I will try to cover some of these topics in my presentation. So, first of all, I did this presentation trying to think how I got to choose my mini implants. So in order to choose them, there are some informations I would like to speak with you about. So what are the things we need to know about TEDs? first the design and then the biological aspects, because as you know, for the design, there are many types of screws. And just in general, for the least experienced orthodontist, the mini screws have a head, a collar, a neck for the thickness of the mucosa, and the core, which is shafted. So starting with the head, we have a various number of head designs. And why do we have them? And which one fits in which case? So I try to select in some of my cases, I like those with the button with the round head, to use them with elastomeric chains, with spring coils. You can use these night eye spring coils with ligatures, or they also make them a little bit larger to fit exactly around the head of the mini implant. Or you can have the design of the mini implant's head with a slot or in a cross type, exactly to use an arch wire, I think with a 19 by 25. I placed some pictures where I use them like this, but I have to say the design that I like the most is with a round head. And when I use, each time I use arch wire for indirect anchorage, I bend it so that it can fit around the head, around the collar of the mini implant. And I place it, a flowable composite to make it a rigid ligature. But in time, each of us, I think, will find our own designs that will function in our own hands. It's just a matter of what we prefer and what is easy to use for us. So the second thing, you will see there are lots of diameters and length. And what we need to know about the diameter and the length, and I have a question, what do you think is most important for the stability? Is it the length or is it the diameter? And the answer is, it's the diameter that is important, because it's the amount of mini implant that gets in contact with the cortical bone. The cortical bone is the one who gives us the primary stability, and we will speak a little bit about this primary stability. So the more amount of cortical bone gets in contact with the mini implant, the stable it is. So the diameter increases the stability. This is one of the reasons we do it angled by 45 degrees, because by placing it under 45 degrees, we increase the amount of mini implant that gets the shaft, that gets in contact with the cortical bone, thus increasing the stability. So what I use the most, it's between 1.5 and 1.6 millimeter. And the length of the mini implant is important for stability only in cases with bicortical anchorage. In this case, it's important. In cases in which is only monocortical, the length of the screw is very important to get the ratio of the mini implant, the quantity of the mini implant that is in the bone and outside the bone, to be at least 1:1. You know, there are zones in the cavity where we have a very thick mucosa. In the retromolar area, for example, the mucosa can be 4 millimeters. So our mini implant, the quantity in the bone should be at least 4 millimeters. That gives us at least 8 millimeters. So it's a very good reason to use 10 millimeters in the retromolar area. So I think this clears everything a little bit up. There are these GS screws. Diego talked a little bit about them, and I know Johnny has nice cases with them. They have a very large neck. It's especially for the gingival part, so that it does not hurt the gingiva and we don't get any irritations. and they do this Jeil, I think, yes, they go up to 16 millimeters, which are very good for the pterygoid area. And I know Johnny will show some cases with those. Okay, and now just a little aspect about the biological part. So the mini implants, they don't get osteo-integrated like implants. We use the primary stability. The primary stability is the stability we get in the same day when we place the screw. This is the reason why it is so important to have this good cortical bone, a good quality bone around the implant, because it gives us the primary stability. It depends on the quantity and quality of the bone, and a close interface between the bone and the mini implant. And the secondary stability, which is in time, starting after the insertion, depends very much on the healing conditions and on the newly formed bone on the interface between the mini implant and the bone. So I won't insist about this, but I'm sure you know bones in the oral zone have different types. So we have a very dense bone in the retromolar area, in the mandible, and in the mental area. We have a second type in the maxillary anterior and lateral side of the mandible. D3 also in the maxilla, and D4 is the poorest bone. It's said to be in the retromolar area. So the bone we want in the for mini implants is somewhere between D2 and D3. The D1 is very dense and thus poorly vascularized. Where in zones where we have D1, sometimes also in adult patients, we might need to do a pre-drill in order to be able to insert our mini implant. So I was talking about the secondary stability in time and the primary stability. And what we don't want to have is, first of all, poor bone quality. Second of all, fibrous interface between the mini implant and the bone. And just a moment. Sorry. Okay. Okay. And third of all, an increased space between the mini implant and the bone. So how can we avoid those things? Mostly the second and the third. We don't want to have excessive force when we turn around the mini screw in the bone. So do not over torque it. And when you feel it's there, don't turn it more around. Don't overheat it. And when you have the, place it always in the long axis. Don't place it and wiggle with it, because it causes micro cracks between the mini implant and the bone. And this gives us an unfavorable result in the long time. So which are the factors that are influencing this success rate or failure rate? About the host, osteoporosis, smoking, age, and gender. Age and gender accordingly to some studies. About the surgery, the improper insertion size. About the bone, in not so good quality bone. The mucosa, in the mobile mucosa, and we'll see afterwards. The lack of initial stability, excessive heat or pressure. If we use a drill, if we use a burr, don't choose the burr larger than the mini implant. Don't make the hole larger than the diameter of the mini implant. We won't get the primary stability. And what we do afterwards, the patient has to have a good oral hygiene to avoid inflammation and infection, of course. Oops, sorry. Okay, second of all, it's what we want to do with the mini implants. So what mechanics do we need to apply? And I won't get into this because Johnny will talk about this, but we can use them in all directions of spaces. We can use them in the vertical plane for intrusion, extrusion, and correcting of occlusal cants. In a transverse, we can do expansion, compression, we can correct the molar or premolar torques and correct the midline. And in the sagittal, we can we can do mesialization, distalization, and space calibration with them. So always think about what we want to do with the mini implants in order to be able to choose the mini implant accordingly. And the second of all, once we know where we want to move our teeth, and we select the anchorage spot, then we can select which type of anchorage do we want. Do we want a direct anchorage or a direct attachment or an indirect? When we will use direct, we can use the elastomeric chains, the nitty springs. It's a very easy technique, but what we have to be what we have to look out for is that the force, the vector of the force, is linear, because always when we pull toward the mini implant, we can have secondary effects. So try to have the force parallel to the movement we want to get. And if we use an indirect attachment, we can use I use the 19x25 stainless steel wire. I use them always in segmental approaches. It gives me a good control and a good rigidity, but I can have the side effects of having unwanted movements on the anchorage teeth, especially if the attachment from the mini implant to the anchor teeth loosens up and I'm not paying good attention to it. So pay attention to that. Okay, and of course, according to the movements and to attachment we want to have, we then select our insertion sites. We already talked about the bone quality. We know we want to have D2 and D3. What about the mucosa? We know we want to have always to place them in attached mucosa and not the mobile mucosa. So we can easily see the line between these two types. And also pay attention to the frenulum. Mini implants in close contact to these frenulums can get irritation of the soft tissue, inflammation, and that leads us to mini implant failure. So try to stay as much as you can in the attached mucosa or right at the limit between attached and mobile mucosa. And then again, what I said at the importance of the length of the mini screw, we can see, especially on the CT, we can see the length of the bone, the quantity of the bone, and the thickness of the mucosa. And we have to have a ratio of 1:1, one of the mini implant that is in the bone and outside the bone. So measure the thickness of the mucosa and add that to the amount of the mini implant that we want to have in the bone. Okay, and then we know we place them between roots. So how can we see the roots of the teeth easily? I always take a periodontal probe and I glide it very soft on the roots of the teeth, and it will get whitened where the roots are, and the periodontal probe will show me where the depth between these roots are. So they would be like this, and we have the line between the attached and the mobile mucosa, and this gives us the point where we can insert our mini implants. And I go first perpendicular, like Diego said, and I go once or twice, and then I go up when I'm in the maxilla or down when I'm in the mandible, so I can get this 45-degree angle that gives me a good stability in the bone, in the cortical bone. Okay, and of course we have the adjacent structures like nerves or sinuses or fossa, And as for the palatal zone, I like this article from Wilmes and Ludwig Börn. It's about the T-zone, a very good spot for the insertion in the median and paramedian palatal side. And like I said, pterygoid anchorage, and this is a case of Johnny Barbour's. I just used it to place it here to get the red line, but he will talk about this a little bit later. Okay, so just for recap, what we have to pay attention. Bone is the quality and the quantity, and we want to have more cortical bone. Soft tissue, always stay in the attached mucosa and pay attention to the thickness of the mucosa. Teeth, we need to have 1 millimeter of bone around the mini implant, or in other words, 0.5 millimeters between the mini implant and the root of the adjacent teeth. So that gives us 1 millimeter around the mini implant and the adjacent structures. And once we know all these informations, it's much easier to pick out the mini implant in terms of diameter, in terms of length, and even in terms of what type of design of the mini implant do I need to be able to obtain this type of movements that I want. Okay, so what do I normally use? Because as we've seen, there are a lot of mini implants and there's no point in having a stock of each one of them. And in terms of length, I use, mostly I use the 1.6 with 8 millimeters or 10 millimeters. Between the first premolar and the second premolar and the first molar in the maxilla, I use 1.6 with 8. In the retromolar area, in the maxilla or mandible, I use 1.6 to 10 millimeters. And on very rare occasions, I have one case I will show you after. I use them in the mental area in the mandible, and I placed 1.4 with 6 millimeters. So smaller diameter and a smaller length, and you will see why. So this is what I use. And for design, I prefer, like Dr. Diego said, also the GA and the G2. I'm very used to them and I find them very handy for everything I need to do. So some tips and tricks and some troubleshooting, because this is very interesting, I think, for everyone to see. First of all, in my segmental cases, in the indirect anchorage, as you see in the first picture, what happens is after I place the mini implant, after some time, some mini implants don't stay put. They tend to migrate also because of the force and because of the way the bone heals around the mini implants. And because I rely myself very much on the attachment between the mini implant and the arch wire, this can be very dangerous for the anchorage teeth. So in the second picture, I did a mistake. You can see on the mucosa above the canine, I hurt the mucosa with the elastic chain because I did not use the force correctly. I should have placed the attachment point on the arch wire more distal, maybe mesial to the bracket on the canine, so I did not hurt the mucosa. And this happened because I did not pay attention when I placed the elastomeric chain over the tissue. The third picture is, in some patients, I get this type of reaction. The gingival tissue proliferates around the mini implants. This does not hurt the patient. It's also associated with maybe a poorer oral hygiene. So we have to make the patient conscious about this aspect. And once the mini implant is out of the bone, everything heals and it will get back to normal. Then in the bottom picture on the left, I use the mini implant in the mental area, where this easily happens because of the lip. The lower lip is mobile, the space is very small, and the mucosa can get very irritated, and this can hurt the patient. So I try to be very quick. I try to use flowable composite on the head of the mini implants. So in order to decrease the irritability as much as I can. Once the mini implant is out, everything gets back to normal. In the second picture, what I did, you can see the oral mucosa is red around the mini implant, and this is also because of me, because I placed the flowable composite too close to the mucosa, and the patient could not clean very well, and it got irritated and inflamed. And in the last picture, also what happens to some patients, especially in this area of palatal side between the second and the first molar, the mini implants tend to get embedded in the mucosa. So if it happens, I derotate it once or twice, and so that it is out of the mucosa. So don't let it in, because it can get totally embedded, and this is not very nice. Okay, so now for some clinical examples. First case, it's an open bite. What I wanted to do in this open bite, I won't present everything here. I wanted to maintain the upper incisors where they are, and just to intrude the posterior part of the upper teeth. So I used mini implants to intrude it, and then auto-rotate the mandible to close the bite. And I use IPR in the lower arch to be able to align the teeth without having any protrusion of the lower incisors. So I used 4 mini implants, 2 in the buccal area and 2 in the palatal area. Why? Because we always want to have a force couple. When we intrude teeth, we want to have an external force and internal force. All of them were 1.8 with 1.6 diameter with 8 millimeter in length. I use elastic chains, and then I use ligatures wire, and also you can see the upper arch is cut because I did not want to have to align the upper front to get to incisally. I wanted the posterior teeth to be intruded. So I worked separately in the front and in the back. So as you can see in the palatal area, I also had these 2 mini implants. I used bite razors, which helped me to intrude the teeth and to stabilize the mandible during treatment. And I used it until I got occlusal contact between the upper incisors and the lower incisors. So after this, I decided to debond the patient, and she got a much better profile because her lower facial height reduced and the lip incompetence went away. This was the result after the debonding. And I also have, so before and after. And the 2-year recall, it's a pretty stable result. She did not relapse. So the second patient with a posterior crossbite, more on the left side, with edentulous spaces on the lower arch. What I decided to do here, and it's not a common treatment decision, but I wanted to close the lower spaces. We did corticotomies in the upper arch and in the lower arch. In the lower arch, as I told you, it's not very common for me. Nowadays, I would like to open up the spaces because it takes too much time to close spaces in the lower arch. But here I decided to close them, also with the help of corticotomies. And what I used here are power arms in order to get the force vectors I need. So in the lower fourth quadrant, this is in the left picture, I used a power arm with a force that went straight from the power arm to the mini implant in order to have a force that gets the tooth translated and not tilted mesially. And in the third quadrant, it looks a little bit more complicated, but it's not actually. It's also a power arm that uprights the root of the premolar. And I use the power chain from the lower incisors to this power arm. And I used another mini implant that stabilized the lower incisors so I don't get secondary effects or negative effects on the lower incisors. And also this mini implant helped me with the power chain to mesialize the molars from the back to the anterior part. So this looks the situation on the debonding day. And he went to the prosthodontist for a calibration. I worked with Rugina here. He did the selective grinding, and after the selective grinding, the occlusal got very well settled and the spaces were closed. So the before and after. But as I said, it's much more easier to open and to calibrate the spaces in the lower arch than to close them. It takes much effort and a lot of time to do this. So the third case, and some of you may have some of these cases, it's a pretty nice young lady who came like this because she was afraid of going to the dentist and she didn't knew she could get any help. So it was a challenging case for me because I needed to intrude the lower front without having posterior support from the teeth, and also calibrate spaces in the upper arch and retrude the upper front, again, without having too much teeth for anchorage. So I used in this case a lot of mini implants, as you will see. I used 2 mini implants in the mandible. These are the cases I told you about. I used 1.4 with 6 millimeters, the mini implants in the lower front. I used them in order to correct the over-eruption of the lower front. Then I used in the upper arch, in the lateral regions, in order to be able to retract the upper front and also to intrude the posterior, which were the molar and the premolar were totally over-erupted. So in time, this was it. We had to calibrate the spaces for implants in the upper and in the lower arch. And I had to, I left 1 mini implant to be sure everything stays stable. And before and after. So we have calibrated the spaces and reduced incisal protrusion and the over-eruption of the lower incisors. I did not see her after I debonded her. She's now ready with the prosthodontist part, and here she is before and after. She did not came to me because she's not living in Timișoara, and because of the pandemic she cannot travel, but she sent me this photo, and it's a total change of character before and after. So another case I wanted to show you. In this case, she's one of my colleagues with a very thin gingival biotype and with gingival recessions. In this case, I was a little bit afraid not to do any more harm to the periodontium, more harm that already was done to it. So I decided to place mini implants in the retromolar area, in the maxilla and in the mandible. I used, all of them were 1.6 diameters with 10 millimeters of length. And the way I treated her was for first distalize, also use stripping and distalize the lateral segments in the upper arch and in the lower arch, using the mini implants in the retromolar area. And only when I had some small spaces distal to the canines, only then I decided to bond everything, so that I did not put extra pressure on the periodontium in the frontal region. So this was the alignment after I distalized using the mini implants, and this was her on the debonding day. So not a very difficult case, but I use this biomechanics to be safer around the periodontium. And the last case I wanted to show you is how I used mini implants in the segmental orthodontics. This was a case referred from the prosthodontist. The patient did not want to have braces everywhere. So for small movements like correcting the crossbite on the 1/6, intruding it, aligning it with 1/7, calibrating the spaces in the lower arch, and derotating the lower premolar, I use indirect anchorage from the mini implants to the premolars. I used the 19x25 stainless steel wire, which was bent around the mini implant and bonded with flowball composite on the anchored teeth so that I could get my movements. And here is the treatment progress in the lower arch. And on the left side, just a small correction, closing a gap between the canine and the premolar. So this was it. The segmental approach is very short, comparing it to a full treatment. It was around 8 months. So this was the final outcome. And I like the segmental approaches very much. I have published into papers. So for those of you interested in this type of treatment, just write me and I will share my information with you very gladly. So as a conclusion, first, know the why and the what. This means do a good proper diagnosis and know your treatment goals, and only after that think about how you can integrate mini implants in order to accomplish those goals. Second, choose the mini implants accordingly to the movements you want and to the anatomical considerations. And 3, keep it simple. Don't overcomplicate with tens, thousands of mini implants and designs. Just use 2 of them and you'll be very good with it. So use the mini implants accordingly to your imagination, but like Vince Kokic said, be aware of the biologic and use it accordingly to the diagnosis and the treatment plan. So thank you very much.